Should we start?
Please hold on, sir. Just in a minute, we'll go on live.
Give me a hint when we should start.
You can.
Okay. Good evening, everyone. Myself, Dr. Lokesh Kumar Saini. I'm Assistant Professor in the Department of Pulmonary Medicine at All India Institute of Medical Sciences, Rishikesh. In the continuation of the webinar series from Indian Academy of Respiratory Care, today we all are here on this online platform to discuss the importance of a very important modality of oxygen therapy, that is high flow nasal oxygen therapy in respiratory care. This program is being organized by Indian Academy of Respiratory Care, the academic wing of Indian Association of Respiratory Care. Indian Association of Respiratory Care is the sole professional organization of respiratory therapy professionals and students of India. So today's program is sponsored by Fisher and Paykel Healthcare. For today, the discussion of utility of HFNC in respiratory care, we will have two lectures by two eminent speakers, followed by one panel discussion for answering and discussing the delegate questions. So I request all of the attendees to post their questions or queries into the chat box, and we will try to take as much as possible during the panel discussion. So without wasting the time further, let's start the program today. For the first talk, I invite Mr. Thomas Piraino to speak on practical implementation of nasal high flow in critical care. Mr. Thomas Piraino is RRT, FCSRT, FAARC, and clinical specialist at St. Michael's Hospital, Ontario, Canada. He's a senior and well-known respiratory therapist from Canada. He has spoken internationally at various respiratory and critical care conferences. He is a published researcher and author on the subject of invasive, non-invasive mechanical ventilation, high flow nasal oxygen, and monitoring in the critical care environment. He is also a member of the editorial board of Respiratory Care Journal and the Canadian Journal of Respiratory Therapy. So over to you, sir.
The opportunity to discuss the practical implementation of nasal high flow therapy. I have some disclosures to make. I have received payment for speaking in the past 2 years from Drager, Fisher & Paykel, and Phillips. So let's first discuss the initiation of nasal high flow therapy. There are probably many different criteria for initiating high flow therapy, nasal high flow therapy. They would be different between organizations, between hospitals. This is just an example of combined criteria that have been used in research studies. So this is an example that if you cannot maintain a patient's oxygen saturation between 90 and 94% while receiving a face mask that is delivering at least 10 liters per minute or more of flow, or if they're on a Venturi device or some mask device that can give a precise amount of oxygen, if they are on 50% or more, and this is what's needed to maintain the saturation of higher than 90 to 94. If the patient's breathing at 25 breaths per minute or more, if you see signs of increased work of breathing, or if they are, and they must be hemodynamically stable. So a patient who meets any of these criteria but are not hemodynamically stable, they may require more urgent intervention in terms of invasive ventilation. But assuming they are hemodynamically stable, this is the typical criteria of when we should consider initiating high flow therapy in patients, or nasal high flow therapy. So in terms of settings, typically many will say you can start at 30, you could start at 40. I use this example because typically most patients will tolerate 40 and 50 liters per minute of flow. So starting at 40 and then increasing it as patients tolerate it to a minimum of 50 liters per minute is likely ideal for many patients. Around 50 liters per minute is the average flow used in many studies after they report. So most will start lower, but then they report the final value, and 50 is typically around the average that's used in most studies. And then you could increase it to 60 liters per minute if there is patient demand or a high respiratory rate that is not seen to be resolved with 40 or 50 liters per minute. So I would quickly try to get them from 40 up to 50. And then if they are still working, they still have a high demand, I would increase that flow to 60 liters per minute. And then if a patient complains of nasal discomfort, you can decrease the flow, but try to maintain a flow of 40 liters per minute or higher, especially in the acute phase. But keep in mind that the size of the cannula may impact the nasal discomfort. So I have a slide here from a paper that was published in Critical Care in 2020, and it was a bench study, but it represents that the size of the nair, the diameter of the nostril, if you have a smaller diameter and you're using a larger tube, or a larger cannula size, I should say, you can see that the pressure generated in the nasal pharynx can be quite high. This is up to 12 centimeters of water. And of course, these are different flow rates. So once you get to 60, you can generate a reasonable amount of pressure when there's not much space around the cannula. Of course, if you have a smaller cannula size in the same size nostril, you can see the generated pressure is much lower. Now, some of this pressure it may be beneficial to be generated, but really the tolerance of the therapy is key. So if you may be generating high pressures, but if the patient does not like it and doesn't tolerate the therapy and begins taking the cannula out of the nose, you need to compromise. So you either need to change the flow rate, which the flow may be helping with other things such as CO2 washout, anatomical dead space washout with the high flows. So you may want to keep the flow, but you may need to change the size cannula that you're using with this patient if they complain that it's too much. You can try lowering the flow, but consider taking a look at the cannula and see if it's maybe taking up too much of the nair. And then finally, starting at a temperature of 37 degrees Celsius is what's recommended, but please note that some patients may find this uncomfortable. There has been a study showing that there's two temperature ranges that were used here, 31 and 37. Patients on average found that 37, there was a lower comfort score. So higher comfort score means there's more comfort. When they looked at patients that were on 31 degrees of temperature, and they found patients were also uncomfortable at higher flows, at flows of 60, if they were on lower amounts of O2. So these are patients that are probably not as severe. They probably don't have as fast of a respiratory rate, as much of a drive, and giving them a lot of flow in their nairs, it may not be comfortable because they really just don't have the demand. Whereas patients requiring more FiO2, they didn't have a problem with the higher flows, but they did have a problem with the higher temperatures. Now, this was 40 patients. This is not generalize all patients that ever get high flow nasal cannulas. So start with the initial recommended setting of 37 degrees Celsius, but don't feel like you're doing something wrong if they complain of the heat. If they say it's too hot, try a different setting. Again, tolerance of therapy is key. 31 is not as optimal as 37 for these patients, but it is something, and it will provide that comfort that will allow them to keep the nasal cannula on. So this is just an important aspect. And if you're using a device that has a medium temperature, then you could use something in between. For example, the Airvo line of devices, I do know that they have a 34 degrees option, so you could meet somewhere in between there. And just to give you an example of this, the best comfort settings, these are pretty equal. And this was high flow at 30, high flow at 60, at 31 degrees. They were the more comfortable settings in this study. And probably the worst combination of settings that they found was 30 liters per minute of flow at 37 degrees. So low flow, high temperature seemed to be the least tolerated in terms of comfort. Now, let's talk about acute management. These are the patients that present with hypoxemic failure or respiratory failure, and I'll discuss both types of respiratory failure, hypoxic, and I'll have a couple of things to say about hypercarbic failure. And these are patients that present, they have acute respiratory failure, and before you decide which therapy to use, you have to consider what is still considered the gold standard. So I would say generally always consider non-invasive ventilation as a first-line therapy if the patient has hypercapnic failure secondary to a chronic lung disease. So acute on chronic COPD exacerbations, you would want to deliver non-invasive ventilation. It is where we have the best data and it is the gold standard. Cardiogenic pulmonary edema, you will likely achieve better pressures to help with the edema and atelectasis by using non-invasive ventilation. And Any development of hypoxemia post-abdominal surgery. So there has been studies looking at high flow nasal cannula compared to non-invasive ventilation in post-op abdominal surgery patients. And again, likely due to the nature of surgery, there may be atelectasis that really requires that dedicated pressure, that sealed interface. And therefore, these are the types of patients that probably you should still use non-invasive ventilation as a first-line therapy. Where you would consider nasal high flow as a first-line therapy is if the patient has de novo respiratory failure. So for those who aren't familiar with the term de novo respiratory failure, a definition would be hypoxemic respiratory failure in the absence of underlying chronic lung disease or cardiac failure. So keeping in mind that patients with COPD or cardiogenic pulmonary edema, they will present with some elements of hypoxemia. So just to say, give non-invasive, to give to everyone nasal high flow who presents with hypoxemia, you have to consider the underlying cause. So when these underlying conditions do not exist, this would fall into the category of de novo respiratory failure. And an example would be community-acquired pneumonia in someone who doesn't have cardiogenic pulmonary edema or COPD. So the average person coming in with community-acquired pneumonia, they would fall into this category. And immunosuppressed patients, although there is current guideline recommendations that non-invasive ventilation could be used in immunosuppressed patients, there's more and more data suggesting that the least invasive you can be with these patients, the better, provided they respond to therapy. So nasal high flow therapy may perform or outperform non-invasive ventilation in these patients. So I would consider nasal high flow as a first-line therapy for these patients as well. Now, just to give you an example of community-acquired pneumonia, I mentioned that de novo would be patients without COPD. This would be an example of patients without COPD. And when you look at patients with COPD, when given non-invasive ventilation, this is a small study, but it demonstrates this quite nicely, that if the patients have COPD and pneumonia, giving non-invasive ventilation as a first-line therapy avoided intubation in these patients. So significant difference in avoiding intubation. All 12 patients here avoided intubation. They received non-invasive ventilation. Standard treatment, which was just oxygen therapy, not nasal high flow, mind you, but this is just standard oxygen therapy. They did not avoid intubation. Patients without COPD, non-invasive ventilation or standard oxygen therapy, there is no difference in the avoidance of intubation. Therefore, non-invasive ventilation does not help patients who, again, in this example, they did not help avoid intubation in this study. So it's important to note that if someone comes in with pneumonia, but also has COPD, you would still use non-invasive ventilation as a first-line therapy. If they do not have this underlying disease, then you would likely want to start with nasal high flow therapy. Now, if you are treating with non-invasive ventilation, you have to understand some of the limitations. And if you look at the risk factors of failing non-invasive ventilation, you'll see community-acquired pneumonia is right there. Acute respiratory distress syndrome is there, and immunosuppression is there. These are all risk factors, as is hypoxemia with a PF ratio less than 150. So again, knowing that there's risk factors, and when patients fail, this is a risk factor for failing non-invasive, and non-invasive failure is a risk factor for mortality. So be sure you understand who you're applying non-invasive ventilation to and when it may be more ideal to initiate nasal high flow therapy instead. So high flow nasal cannula compared with conventional oxygen therapy for acute hypoxemic respiratory failure. This was a systematic review and meta-analysis that was published just prior to the guidelines that were discussed. And this found that overall, there was one study that got everyone very excited, showing a reduction in mortality in patients treated with high flow nasal cannula or nasal high flow therapy compared to standard oxygen therapy and non-invasive ventilation. However, when all studies are combined that currently look at this as an outcome, they found that overall, if you're not familiar with forest plots, anything that crosses this one means that it was there's no significant difference between high flow nasal cannula or standard O2. You want this black diamond to be sitting on one side or the other. If it crosses, there's no significant difference. So mortality, we still don't have enough data to suggest that nasal high flow therapy will reduce mortality in patients. However, we do have data suggesting that you can avoid escalation of therapy, pardon me. So this is avoidance of non-invasive ventilation would be an example, or avoidance of intubation, which is the next slide. And you can see overall, the black diamond is in favor of high flow nasal cannula for avoiding the escalation of therapy, and the need for invasive ventilation also favoring high flow therapy, nasal high flow therapy. So this was the systematic review that really pushed the guidelines forward, I would say. Many of these studies obviously did, but the guidelines, the reason why they recommend high flow therapy or nasal high flow therapy for patients with hypoxemic respiratory failure is because of this ability to avoid escalation of care and the need for invasive mechanical ventilation. This paper did find that there was a 4.4% absolute reduction in the need for intubation. The number needed to treat 23, which is not a very low number. Ideally, you would want this number needed to treat much lower, but you have to consider that. So if you treat 23 patients, at least one will avoid intubation. But in some therapies, 23 may not be good. For example, if you were giving a drug that after 23 patients that received the drug, one person would avoid poor outcome, but there were side effects to the drug that caused other problems, then a number needed to treat of 23 would not be ideal because there would be harm in the therapy or other issues created with the therapy. Nasal high flow therapy is not one of those things. There is no evidence that nasal high flow therapy will cause any harm or any other concern. So because it's a safe and effective therapy, it makes sense to use it in the context of hypoxemic respiratory failure over using something like conventional oxygen therapy. So there you have it. Now, in terms of hypercarbia, the jury is still out in terms of, what are the boundaries for using high flow nasal cannula or nasal high flow therapy in patients who are hypercarbic. And this is an interesting paper published in the Annals of Intensive Care Medicine in 2019 that looked at work of breathing compared to non-invasive ventilation and then different flow rates of high flow nasal cannula. And please forgive me if I switch between nasal high flow therapy and high flow nasal cannula. I'm referring to the same therapy, and I'm sure you're aware of that. Many of the papers will call it high flow nasal cannula. So they compared non-invasive ventilation, and when switched to high flow nasal cannula, you can see compared to non-invasive ventilation, if you want to look here, this is probably the easier one to look at. It's the pressure time product per minute. You can see that it increases compared to non-invasive ventilation. High flow nasal cannula at 20 liters per minute, it's still elevated. High flow nasal cannula at 30, you can see it's now fallen back into the same area as non-invasive ventilation. And then we have high flow nasal cannula at 40. You can see it's quite similar, but 50 is now increasing again. And I would suspect that 60 may have actually increased even higher. The point of this slide is that with COPD patients, or with hypercarbic patients, I should say, we may find out that the level of flow is extremely important for COPD patients. And I think we still need more data to not only determine which is the ideal patient who's in hypercarbic failure, where they would benefit from high flow therapy, nasal high flow therapy, and perhaps what flow rate is ideal. And of course, it won't be the same for every patient, but on average here, the number of 30s seem to be better than the other flow rates. So just to keep in mind that flow is likely important. There is one systematic review and meta-analysis that I was able to find when I looked this subject up in 2020. The issue with this systematic review, so what it showed is that high flow nasal cannula compared to non-invasive ventilation, it appears that there's no difference in the management of hypercarbia. So one might take this information and assume that this means that you could treat hypercarbic respiratory failure with high flow nasal cannula or non-invasive ventilation and have the same outcome. However, there were 5 randomized controlled trials included, and 3 of them were extubated patients. So you have to understand that patients who are hypercarbic after they've been treated medically, so they're not actively in failure, they're actually in the recovery phase, but still hypercarbic, are very different than the patients who present to an emergency room or the intensive care unit who are in acute failure with hypercarbia. Obviously very different patients. So the fact that 3 out of the 5 randomized control trials included extubated patients, it doesn't really answer this question at all, whether or not high flow nasal cannula is similar to non-invasive ventilation for the management of hypercapnic respiratory failure. Good news is we have upcoming studies. This is just an example of 2 protocols that have been published online for studies that are planned and or ongoing currently. One is the comparison of high flow nasal cannula and conventional oxygen therapy for support during acute on chronic respiratory failure. This is a multi-center randomized control trial. And then this is a high flow nasal therapy versus non-invasive ventilation in COPD patients with mild to moderate hypercapnic acute respiratory failure. And this, again, these are just publications of a study protocol. And this study would be a non-inferiority randomized control trial. Non-inferiority randomized control trials are typically what's used when something is already established as a gold standard. And because non-invasive ventilation is a gold standard in this clinical context, then you would need to do a non-inferiority trial to see whether or not high flow therapy is as good or non-inferior to non-invasive ventilation. So this is the study I'm probably most excited to see the results of. I think this one really would be specific to answer the question which I brought up in the last systematic review. To summarize acute management, non-invasive should still be used. This is non-invasive ventilation in the form of BiPAP. So 2 pressures should still be considered the first line therapy for certain patient populations. And that goes without argument right now. We should consider high flow therapy when oxygenation cannot be sustained with less than 10 liters per minute of oxygen flow, direct or with providing 40% oxygen or less. So once they're on 50% or needing 10 liters per minute or more, we should consider moving forward, and or when work of breathing appears elevated, and of course respiratory rate is elevated. Most guidelines will use a respiratory rate of 25 to 30 as a threshold for starting high flow therapy. Nasal high flow therapy may avoid escalation of therapy and the need for invasive ventilation. We have data to support this, and this is why the guidelines recommend this. And more data is required for suggesting treatment of acute hypercarbic respiratory failure. There are many studies ongoing looking at this, and we still need more data before we can make a conclusive argument. For now, non-invasive ventilation for hypercarbic failure is still first-line therapy. So monitoring of high flow therapy, this is important in terms of how do you know your therapy is being effective? And why this is important is because there is always a concern with non-invasive ventilation that you are delaying intubation. And there is evidence that delaying intubation in a patient leads to poor outcomes. So currently, there are not many studies in the potential delay in intubation related to delivering high flow nasal cannula. There is this paper in Intensive Care Medicine published in 2015 that basically showed that patients who are intubated earlier, so this is early high flow nasal cannula failure compared to late high flow nasal cannula failure, the overall ICU mortality, extubation success, ventilator weaning, and ventilator-free days are all significantly better in patients that fail earlier rather than those that fail late. Now, the issue with studies like this is that late failure could be a progression of a condition. It doesn't exactly mean that the patients were failing earlier, and that's what's important to understand. So I'm going to talk next about a score that's been used, that has been used clinically, and I'll bring up some of the papers that have used this score. But the purpose of the score is to see if the score would have predicted failure of high flow nasal cannula. And if it does predict failure of high flow nasal cannula, perhaps early intervention will avoid poor outcomes. And this is the whole concept behind what this paper published, which is the ROX index. So the ROX index, it looks at saturation divided by FiO2 divided by respiratory rate. So the beauty of this score, the simplicity of it, is really what makes it a nice tool. And I'll talk about some of the limitations of the values that are used and how we can work around this. But really, it's things that are readily available. If you have a saturation monitor, you know what FiO2 your patient is on, and you know the respiratory rate, you can calculate the ROX index. You don't need any blood work. You don't need an arterial blood gas or a venous blood gas. You have everything you need. Now, in this paper, I want to make it very clear that this paper did not use the ROX index to determine whether or not they were going to intubate a patient. The purpose of developing this score is to see if you could predict failure in a patient, and if you can predict that they're going to fail, then perhaps you should intervene earlier. That was not the purpose of this paper. This study literally was a study of high flow nasal cannula. They had patients that met criteria for high flow nasal cannula. All of them, the respiratory cause of failure had to be pneumonia for inclusion to the study. And this is important because I'll talk about some other studies that have looked at the ROX index. And if they don't get the same results, it could be due to the fact that this study only included pneumonia, hypoxemic respiratory failure. But they had very strict criteria. Again, the study was just collecting data on patients that needed high flow nasal cannula. So inclusion was the patient had to have respiratory failure caused by pneumonia. And then when they would initiate high flow nasal cannula, was when they could not maintain saturation, oxygen saturation above 92 while receiving standard oxygen administered through a face mask at 10 liters per minute or more, and the patient had a respiratory rate of 25 breaths per minute or higher. They would start high flow nasal cannula at 30 liters per minute and titrate up for patient comfort, and start with an FiO2 of 100 and then reduce to maintain saturation. They had very strict criteria. And again, these patients were just being followed while being provided high flow nasal cannula or nasal high flow therapy. They had strict intubation criteria, decreased level of consciousness with a GCS score of 12, cardiac arrest, arrhythmias, and severe hemodynamic instability, or persisting or worsening respiratory condition defined of at least 2 of the following criteria: failure to achieve correct oxygenation. This means a PO2 less than 60 with SATs less than 90, and high flow is greater than 30, and they're on 100%. So if they meet this criteria and any of the others, which could be respiratory acidosis, a resp rate above 30, or inability to clear secretions. Now, the reason why I've put resp rate above 30 in bold is because this is their criteria for intubation, but it is also the denominator in the ROX index. So if your criteria to intubate is a resp rate of 40, then your denominator would be different for every patient who you then decided to intubate, and therefore the score may not be as effective. So you need to understand that if this looks similar to your intubation criteria and your patient has pneumonia, this ROX index may perform the best because it is the closest to what was done in this study. I'll talk about an external validation that was done with this that did not perform as well, but there are reasons for it. So what they found is that a ROX index greater than or equal to 4.8, this was a general overall score that they chose based on a mix of sensitivity and specificity, but it's predicting success. So higher than this is success. And I have this 2x2 table, which is a typical table used to calculate sensitivity and specificity. If you're not familiar with it, I've labeled these things to make more sense. If you know, so what they did is they looked back at all the patients in this study and decided based on who failed and who didn't fail. Again, the ROX index did not decide who failed. They just went back and looked to see what number of a ROX index could distinguish between failure and non-failure. So sensitivity is this column here. So how many patients does it correctly identify? And then for those who are successful, but they actually would be labeled as failures, so a number less than this would be patients that are missed. And this depends on the sensitivity. So the higher the sensitivity, the less patients are missed. The lower the specificity, the more patients you have that are false positives. So they may be above this level, but they actually end up failing intubation. So as you can see, it's a relative mix of sensitivity and specificity at 2 hours. Positive predictive value is a little bit low here. And then as you go further along, 12 hours, 18 hours, 24 hours, you can see the sensitivity increases. So less patients are missed, but the specificity goes down. So you will have some patients that may actually fail, but we're above this level. So overall, this was the score, and it had good diagnostic accuracy, basically that got better as time went on. Now, what they did, and this is what I appreciate about this study, is they looked and thought, okay, well, you don't want to have a lot of people that are, this would be considered overdiagnosed or false positives. You don't want people who are going to fail or succeed and label them improperly, and if the result is to intubate them. So what they did with this score, this is, instead of being greater than, this is less than. So now it's predicting failure, different than the previous slide, which is predicting success. So notice how I have success here. Now I have failure. It's trying to predict failure. Now you'll notice the sensitivity is very low, meaning many patients are missed. That means that many patients that are above this level will likely fail. But if you're using a cutoff as a reason to intubate somebody, you do not want false positives. You don't want to intubate someone who was not going to need intubation. So what they've done with these cutoffs is they chose cutoffs with the highest specificity, so the lowest possible amount of false positives, so that you won't be intubating a patient who may not need intubation. So you'll see 99.2% here, 99.2% here, 98.4% here, which gives you a positive predictive value, which is 83 here, 94, and 89 when I'm rounding up. So you can see it's these thresholds, less than these numbers at these time points, highly indicate that your patient is likely going to need intubation, and you can feel confident that you're not going to be intubating someone who would be otherwise successful. Again, keeping in mind that these cutoffs were specific to patients with pneumonia, and the intubation criteria in the study was not the ROX index, it was a resp rate of greater than 30, and other criteria. So just keep that in mind. But the likelihood ratios, you can see, are very high, the positive likelihood ratios. So it was very good at predicting failure with these cutoffs. Now, they did an external validation with the Flow trial, which is the large randomized trial comparing high flow nasal cannula or nasal high flow therapy with standard oxygen therapy and non-invasive ventilation. And as you can see, 82% of the patients had pneumonia, so not all of them, but the majority of the patients did have pneumonia, but their intubation criteria in the study included a respiratory rate greater than 40. So of course, this 40 would really change the denominator. So they did not have good sensitivity or specificity or positive predictive value or likelihood ratios across the board for using 4.88 as a cutoff. Now they didn't have 2 hours, so they had to use 1 hour. With the Flow data at 1, 6, and 12, you can see with those cutoffs that had very high specificity in the ROX study did not perform as well with this also. So they looked at other things is there other elements of the ROX index that could be used? And what they found is that looking at the difference between 1 and 12 hours, so if you measure the ROX index at 1 hour post initiation of high flow nasal cannula, and then 12 hours later, they found that the difference between 1 and 12 did predict success of high flow nasal cannula. So perhaps this is another way of using the ROX index. Does it increase? So this is an increase of at least 1, and this was significant. And then they looked at the ROX data to see if this difference also held true. And you can see the difference, they didn't have 1 hour, they had 2 hours. The difference between 2 and 12 actually was the stronger value here, but it was a change of 2. So in the Flow it was a change of 1, here is a change in 2. So on the side of playing safe, I would probably suggest that if you have a change in 12 hours between 1 or 2 hours and 12 hours of a ROX index that is at least 2 or greater, it's probably quite predictive of success. This patient is definitely moving in the right direction. So this is a study of immunocompromised patients that looked at these cutoffs as well, and they found, again, very poor accuracy for predicting success of high flow nasal cannula. Their intubation criteria in this study was basically clinical status. It included respiratory rate, but not a specific value. So again, they did not have very strict, and I think this is the reason why the ROX index performed so well in that study, in the ROX study, is because they had very strict criteria for intubation, and it was the same as what was used to develop the score. And that respiratory rate of 30 being very specific, I think, is partially due to this. So it had poor diagnostic accuracy. However, they did find that if you separate patients with a score above 4.88, or less than or equal to 4.88, there's definitely a difference in patients who required intubation, and it's a significant difference. So it definitely was able to distinguish those that were intubated and those that were not. So why does it have poor diagnostic accuracy? Well, that can probably be shown in the first table, actually, which is when you look at the ROX index in patients who needed intubation and those who did not, you can see that, yes, the numbers are significantly different, but when you look at the range in numbers, it goes up to 7 here, whereas here, obviously, it's starting at 4.48 and going up to 8. There's a huge overlap. So when there's a lot of overlap, it makes the diagnostic accuracy of a specific value very difficult to be accurate. So using a specific cutoff of 4.88 was not ideal. So they did find that the ROX index at 6 hours per point increase was associated with a reduction in the need for intubation. So it was significantly associated with success of high flow therapy, and it outperformed many other variables that they looked at in a multivariate analysis. So again, the area under the curve was still poor. So its ability as a diagnostic accuracy in terms of with using one value to predict, it was not good, but overall it did change it. So this is actually one of the suggestions they gave, and I actually like this concept of, they talked about suggesting a concept of risk stratification, and so for quartiles of ROX. So instead of saying it's a certain number, they're definitely going to fail, let's intubate. What if you categorize patients as a level of risk? So here they separated the ROX index in quartiles, and you can see that the interquartile ranges actually don't overlap. So these boxes don't overlap each other. And so this would be someone at high risk, this would be someone at low risk. So this, if you call this risk level 1, 2, 3, and 4, again, how closely you monitor, how much you consider this patient's full-on medical picture to make decisions. If someone's in the low-risk category, then they may be better off. If they're at this level here, again, this may be more helpful rather than trying to focus on a very specific cutoff perhaps risk stratification would be the next step. So further data, I think, should be published with the ROX index. I think more people should use it. I think it's a very helpful tool because it does not require any blood work. It's extremely easy to use at the bedside, and more information like this is useful because these were immunocompromised patients that weren't all necessarily specifically pneumonia. Again, the intubation criteria wasn't specific for respiratory rate, so it's not surprising the ROX index didn't perform as well, but this idea of stratification is actually a good concept. It has been used in a couple of COVID-19 studies. These are research letters, so they're not full studies, but a lot of people were publishing research letters in 2020 due to the pandemic, just trying to get information out there. They found a ROX index greater than or equal to 5.37, had good diagnostic discrimination for whether or not someone would succeed on high flow nasal cannula. Sensitivity is quite low, specificity is higher. This was after 4 hours of therapy. Another paper looked at the ROX index at 6 hours and found greater than 5.55 to be a good, to have good diagnostic accuracy. You can see the area under the curve here. By the time it gets to 6 hours, it's 0.79, 0.82 at 12 hours, and 0.87 at 24. So again, good diagnostic accuracy using a threshold of 5.55 in this paper. So two different papers looking at COVID patients found something sort of in the 5 range to be something significant with it. Again, more data is needed. These were not extremely large studies. They're research articles, research letters. But definitely encouraging to see many people using this ROX index so that we can really narrow down the benefit of using this tool. This is a paper published by Tommaso Mari and colleagues, published in 2019, that I think is extremely important, that patients with a low ROX index at baseline, many of the patients which they labeled as responders, increasing flow was able to increase the ROX index. So if you have a patient with a poor ROX index at 1 hour or 2 hours, don't just say, okay, and then monitor it again 6 hours later or 12 hours later. See if there's room to move with flow. If you're currently at 30 or 40 liters per minute of flow, consider increasing the flow again to a maximum of 60 liters per minute and see how the patient tolerates it. And how this may affect the ROX index is most likely due to the reduction in respiratory rate that can occur when higher flows are used. So the monitoring summary, the ROX index is a promising monitoring tool. Intubation criteria is likely important for generalization. So if you want to use the strict values that are provided, you may have to consider what your intubation criteria is. Further studies should consider risk stratification. I think that's a good concept. Flow settings can impact the ROX index, so consider increasing flow when the ROX is low. And comfort with higher flow rates may be related to cannula size and humidification effectiveness. So that concludes all of the practical implementations of using nasal high flow therapy that I wanted to discuss. You can follow the Center of Excellence in Mechanical Ventilation blog at coemv.ca, and you can.
Okay, it was a wonderful talk from Mr. Thomas Querno. He gave us insight regarding when we can use HFNC and when not, especially when we cannot use. He gave us the concept of acute hypoxemic respiratory failure de novo. When the underlying lung is healthy, we can use HFNC. But if the underlying lung is diseased already, maybe with COPD in acute hypercapnia, then we should not use HFNC in each and every case. Okay, so a message to all attendees, please give your message, the questions or queries into the chat box, and we will take these questions in the panel discussion. Okay, so let's move to our second talk of the day, for which I invite Ms. Jolie Jackson to speak on use of nasal high flow therapy in COVID-19. Julie Jackson is BS, RRT, ACCS, RCP. She is Director of Respiratory Care, UnityPoint Health, Des Moines, Iowa. She is a highly experienced and published respiratory therapist. She is the Manager of Respiratory Care and ECLS at UnityPoint Health, Des Moines, Iowa, USA. She is appointed by AARC to AAMI Foundation National Coalition to promote the safe use of complex healthcare technology. She is a member and co-chair of Respiratory Care Subcommittee in 2017. She is a AARC Management Specialty Practitioner of the Year 2016. She is a member of Adult Acute Section from 2003 to present day. and she is a member of management section from 2003 to present day. So it is over to you, madam, please.
Des Moines, Iowa. Today, I'm going to talk a little bit with you about advocating for nasal high flow therapy and really how you can drive change across your hospital by using high flow therapy. So my objectives for today are to describe the rationale for using nasal high flow therapy across the continuum of care, including in the ED, ICU, on your med-surg floors, and at home. Outline our implementation strategies and factors critical.
Jitin, the screen is not visible.
Yes. There is some technical issue right now. We will take care of it. Please be with us.
Good evening, everyone. I am Julie Jackson, and I am the manager for respiratory care and ECLS services at UnityPoint Health in Des Moines, Iowa. Today, I'm going to talk a little bit with you about advocating for nasal high flow therapy and really how you can drive change across your hospital by using high flow therapy. So my objectives for today are to describe the rationale for using nasal high flow therapy across the continuum of care, including in the ED, ICU, on your med-surg floors, and at home. Outline our implementation strategies and factors critical for successful adoption of nasal high flow throughout the hospital, and discuss the utilization of nasal high flow therapy during our pandemic. I would like to disclose to you all that I am a consultant for Fisher and Paykel Healthcare. I am on the Speakers Bureau for Monahan Medical Corporation, and I also sit on the Medical Advisory Board for Vieira Medical. So to give you a little bit of background about UnityPoint Health Des Moines, we are a large tertiary medical center in the middle of the United States in Des Moines, Iowa. We are a level 1 trauma center, so we have about approximately 800 staffed beds. Our ICU is what we consider a mixed medical surgical ICU, which means we don't have just an ICU for neurosurgery or cardiac surgery or medical patients. Our ICU is mixed with all kinds of patients in it, and we take care of varying patients within one ICU. We have a 36-bed ICU that can flex to a 42-bed ICU if need be on our main campus. We have a 10-bed ICU at one of our other campuses, and then we have a 6-bed ICU at our West campus as well. So this is a fairly
We are facing some technical glitches. Please stay on the line and we'll come back ASAP. Jitin, can you please unmute?
We began to use high flow in our adult ICU. Initially, we used the OptiFlow system by Fisher and Paykel, and we were mostly using it for patients who we were kind of concerned that they may not extubate very easily from the ventilators, so we would try to put them on post-extubation. And then anybody that was intolerant to non-invasive ventilation, maybe they just couldn't be on it, maybe they're claustrophobic, they were freaking out every time we put them on non-invasive. So we utilized high flow in that nature. And then in 2012 through 2014, we expanded our use to really avoid intubation. How could we utilize the therapy to help us keep patients off of the ventilators? And then in 2015, we actually published a retrospective data that we had collected on our successes of using high flow in the ICU that we had from 2012 to 2014. And we published that in the October 2015 Respiratory Care Journal with what our successes were with those patients. And what our successes were is our results kind of provided us preliminary evidence that early use of nasal high flow is beneficial in our medical and trauma ICU population. We saw a decrease in ICU and post-ICU lengths of stay, which reduced, and we also saw a reduction in adverse events. And from this, we concluded that high flow should be considered early in the ICU as first-line oxygen therapy for patients with acute hypoxic respiratory failure. This study was really big for us because we wanted to be able to prove that we might be able to come up with a protocol that would help us determine which patients should be on high flow and which patients shouldn't be on high flow. We also then took a look at our next subset of patients and proactively started using high flow with that protocol that I talked about that we developed, and really wanted to talk through what we were going to, how we were going to use that protocol to treat critically ill patients within our ICU. And we went ahead and published that data in March of 2018 of Respiratory Care. And what we found from that data was we evaluated the prophylactic use of nasal high flow in 2 critically ill populations, the newly extubated subjects and subjects with escalating need for respiratory support. We wanted to evaluate whether protocols that standardize nasal high flow use in these populations prevented any unanticipated respiratory compromise and any adverse outcomes. And we hypothesized that receiving nasal high flow per protocol would reduce the rate of unplanned intubation or re-intubation in our heterogeneous population. So what you can see here is the 2 different subjects that we evaluated. Those subjects that were evaluated for extubation, they were extubated to high flow at 50 liters. And we titrated oxygen to maintain saturations greater than 92%. Once they got to 4 liters, then we went ahead and discontinued them. And what we were really looking at is, did any of them fail and did any of them succeed? As far as just the oxygen group, which meant that they had to come into the ICU. And if they needed more than 4 liters of oxygen while they were in the ICU, then we were going to go ahead and put them on high flow. Again, we started at 50 liters, and 92% to maintain their FiO2. And then we stabilized them. Once they were stabilized and they were in less than 40% for 4 hours, then we would try them back on a nasal cannula. And again, we were looking at our failure rates of having to restart high flow, or whether or not they were successful and they discontinued high flow. And this is a very busy slide, I know, and it's very difficult to kind of see all the numbers, but basically what happened with the first cohort and the outcomes from that publication is we found that we were able to lower their infection and reduce, and had a reduction in bronchodilator therapy. And remember, this is the group that were being extubated to high flow. So we saw, by getting them extubated to high flow sooner, we saw a reduction in infection because we didn't have that ET tube anymore, and there wasn't the worry about ventilator-associated pneumonia. And we actually saw that these patients had a reduction in how often they needed bronchodilator therapy. With the second cohort, and remember, that's the group that came into the ICU and needed more than 4 liters. So we were going to proactively put them on high flow to try to keep them off the vent. What we saw with them is a decrease in their length of stay in the hospital as well as their ICU stay. So that really led to us to think about, why would we want to implement this, or how could we possibly implement this outside of our ICU? What we did is we took a look at how we were currently utilizing it within our facility. We wanted to see like what types of patients were coming to our ICU that were getting placed on high flow. So those patients that were coming over from med-surg floors, and what was required, or why were they requiring high flow. So we took a look at our, what we call our MET-DED, or our medical emergency teams, or some of you may call them rapid response teams. And we identified specific patients who we thought could benefit from the therapy. So whether that was that they had increasing respiratory distress or oxygen requirements, we didn't want them to go on a mechanical ventilator. We thought maybe they would benefit from that versus nasal, or versus non-invasive ventilation. We looked at our ED patients. How many of them were coming in with increasing respiratory distress or oxygen requirements? How many of them were on non-invasive ventilation pre-hospital? So they were coming in with what we like to call squad CPAP. And how could we maybe potentially discharge some of them to home? And then in the United States here, we seem to have an issue with bed flow capacity in our ICUs and our ED, meaning that we oftentimes have patients that will sit in our ICU or ED for several days because they can't go out to the floor because they're on this high flow device. So we were looking at throughput and how could we get patients moved along in the system quicker. And then obviously the benefits to the patient: improved outcomes. They would be more independent because they wouldn't be tied to a ventilator, of course. They wouldn't necessarily have non-invasive ventilator in front of their face. We could mobilize them. They could communicate better to us. And then obviously we could give them better nutrition. So we really felt that we needed to come up with some sort of strategy. If we were going to move this outside of our ICU, we needed to come up with a protocol. We needed to look at this across the board and really figure out how we were going to utilize the therapy, which we did. We created a protocol. We went out and we trained nursing staff about high flow, and then we implemented it. And this paper that we published in August of 2020 of Respiratory Care really talked about our process of how we implemented high flow nasal cannula outside of our ICU. So as you can kind of see here very quickly, our timeline. So in the fall of 2017, we wrote the protocol. We trained residents and physicians. In the winter, we moved the nasal high flow out to our respiratory and trauma floors. By spring of 2018, we had moved it to our ED. By summer of 2018 into spring of 2019, it was moved out to the rest of our floors. And then we continued to move it across all of our hospital systems, those 4 hospitals I talked about earlier. And then in June of 2019, we realized we really needed to have a better, robust weaning protocol related to that nasal high flow, because then our problem became we couldn't get patients off of it once we get them out to the floor. So we really focused on that weaning protocol. Just to give you a little background, this is our criteria for who is placed on high flow. So anybody with hypoxemia, acute hypoxemia requiring greater than 4 liters of oxygen to maintain a goal SpO2. If they're dyspnea, if they have dyspnea or they have an increased work of breathing, if their traditional nasal cannula is not meeting their flow demand or their FiO2 requirements, if they have thickened secretions, especially patients that have tracheostomy tubes, if they don't tolerate non-invasive, we will use it for palliation of air hunger or the feeling of air hunger or hypoxia at the end of life. Who we do not use it on are patients that are obtunded or unable to maintain their airway, anybody that has severe respiratory acidosis or ventilatory failure. So if your pH is less than 7.25, we're likely not going to use it on you initially, though I will tell you during COVID that was a little bit different, but I'll go through that in a minute. Anybody that has facial fractures or skull fractures, obviously this is high flow. We are blowing air up into their nasal cavities, so we didn't want to put them at risk for anything additional. Anybody that has shock or upper airway obstruction. Use on the high flow outside of our ICU does require a pulmonary or trauma service consult, so we have to have a physician evaluate them. This is just our group of physicians that take care of most of our patients. Even outside of our ICU, we do have some hospitalists that do that as well, but this is the group that will kind of manage them. There's RT assessments and documentation done every 2 hours. We do arterial blood gases both before we start and 30 minutes after. We do not require any additional monitoring, so we do not put these patients on pulse oximetry or telemetry monitoring unless they need the telemetry monitoring for a telemetry reason or cardiac monitoring for a cardiac reason. We are able to use transport devices to help move patients around the hospital. So we have some portable units that we have purchased. Sometimes if that doesn't work, we'll put them on non-invasive to mobilize them or put them on a non-rebreather mask to mobilize them to another location if we need to move them. So kind of and I mentioned this earlier, the groups of people that we educated was nursing, respiratory therapists, providers, and physicians. Some of the topics that we covered, we really focused in on theory and physiology for everybody so they'd understand how the theory and how the device works. We focused on protocols, so everyone was aware of what the protocol looks like. As far as documentation and device maintenance, that was kind of pretty much left to the RTs and nursing. And then de-escalation and weaning was a focus for the entire team. So the bottom line for us was we had, with our protocol, we had 998 patients that received nasal high flow within our system. 652 of those were actually initiated and discontinued in our ICU, but we did have 346 that were actually part of our sample size. And you can see they came from the ED, they came from the ICU, they kind of came from all different places. And we initiated some of them on the floor that never ever went to the ICU as well. So with this paper, we had over 1,000 adult patients managed with nasal high flow. These patients were started outside the ICU, which includes ED and floor. The majority of them avoided ICU, so 74% of them avoided ICU. Most of the time, they were only on the device about an average of 2 days. Our COPD patients that came in with adult or with acute hypoxic respiratory failure were in the hospital 1 day less compared to the control group, and they avoided the ICU 81% of the time. We also found that we had low complication rates. We only had 11% of our total patients that needed escalation of care, which meant that they had to go to the ICU for either invasive ventilation or non-invasive ventilation, and only 12% mortality rate. So we found it to be very safe and effective therapy that we could use outside of our ICU. So then along comes COVID-19. And as most of you know, in the early days of COVID-19, here in the United States, there was a theory that we needed to intubate everybody very early, meaning early was defined back then as anybody needing more than 6 liters of oxygen. Hospitals here in the United States became overwhelmed. We were finding that patients had prolonged ventilatory times where they could be on the vent from anywhere from 9 to 17 days. There was human resource shrinking resources, so there wasn't enough nurses, physicians, therapists to care for these patients. There was concerns there wouldn't be enough ventilators. What we saw out of New York City, based on a publication that they had posted in April of 2020, is that it had a very high mortality rate, upwards to 80+%. We also knew that there were a lot of centers that were not big in using high flow during this time frame. And there was some concerns with infection transmission and whether or not high flow was going to transmit infection to not only the patient or family members, which at this time we weren't even having family members, but more or less the healthcare workers. And much has changed since those early days. This was a study that was published in the American Journal of Respiratory and Critical Care Medicine in October of 2020, where they compared high flow nasal cannula versus conventional oxygen therapy in the ICU. And they really looked at some similar comparison groups where they started high flow out at 50 liters to begin with. And what they found was that patients that were using high flow nasal cannula had significantly less days of invasive mechanical ventilation, 56% versus 75% in the control group. Those that were using high flow nasal cannula had lower SOFA scores at 1 day. They were only on high flow for a duration of 4 days, and that they had lower mortality trends in these patients. So our experience with using COVID-19 is what I would like, or using high flow with COVID-19 patients is what I'd like to focus a little time on here. So our COVID-19 protocol was the same protocol that we had prior, but we made some revisions. So we added that we wanted to look at patients that had PF ratios greater than 150. We still were requiring anybody that needed more than 4 liters or 50% oxygen and had an adequate respiratory rate. If they were asymptomatic hypoxemia or evidence of end organ or tissue hypoxemia, we were going to support those patients that were DNR and DNI. And if they did need to go to comfort care, we were going to use non-rebreathers instead of nasal high flow. There were a lot of concerns initially, as I mentioned earlier, with exhale dispersion and the risk of infectious transmission to healthcare workers. And so we went out and did some research, and there was a great study published that really looked at exhale dispersion evidence and really found that there is a very low risk of transmission to healthcare workers. So as you can see in this particular chart, you can see that the risk of exhale dispersion and transmission is way less with high flow nasal cannula or high flow nasal oxygen therapy than even your traditional nasal cannula or some of your other more traditional things like non-invasive ventilation. So what we did is we put together a protocol that said that we must wear droplet, we must follow droplet precautions, use contact precautions, and eye protection if we're within 6 feet of the patient. So that means we wear gowns, gloves, and a surgical mask with eye protection when we're within 6 feet of the patient. The room procedures for us are droplet plus contact, so we do not have to have a negative airflow isolation room for these patients. And if we're in the room with the patient, we also can have the patient wear a surgical mask if need be, or if we're going to transport them, we have them wear a surgical mask over their face when the high flow is on as well. So as far as safety goes, we typically don't move patients to the ICU unless they get maxed out on therapy. So there's quite a bit there that we can do. And we use the Airvo 2s outside of our ICU. So they have to get to 60 liters and 100% basically before we consider them maxed out on therapy. So a lot of our patients can be managed on the floor. Our pulmonary critical care providers have the final discretion if we're going to transfer the patient or not. And then every patient that is COVID-19 that is liberated from the vent is placed on high flow right before extubation. So we'll hook up the high flow, get it all ready to go, and then it's all ready and up and running on the patient, and then we'll extubate the patient. How do we evaluate for the effectiveness? We do that prior ABG and 30 minutes after to kind of see where the patient's at. We do utilize the ROX index assessments, and that's a very well published document that is out there that was published in, I believe it was June of 2019. We use RT assessments. So every 2 hours, the RTs are going into the room and checking pulse ox, respiratory rate, ROX, how the patient's tolerating, whether or not the water needs to be changed, and documenting all that and really doing a full RT assessment on the patient. And once the patient becomes stabilized, we will begin to wean them after 24 hours. We were able to present some of our initial data at the AARC's Winter 2020 virtual conference. We did this abstract that we were able to present on high flow cannula for acute hypoxic respiratory failure in COVID-19. Our outcomes are going to be kind of twofold based here, in that we're going to look at the outcomes for March through June of 2020. That was what we considered our first surge. We had 321 hospitalized COVID-19 patients. Of those 321, 116 or 36% required escalation of care due to acute hypoxic respiratory failure. And our definition of escalation of care means that they had to either go on nasal high flow therapy with Airvo, Optiflow, whatever. They needed to go on non-invasive ventilation, or they needed to go on, become intubated and go on mechanical ventilator. And what you'll see is 83% of those 116 patients that required escalation of care actually received nasal high flow as their escalation of support modality. 61% of those patients were male with a mean age of 64 and a BMI of 32. Of our nasal high flow patients that were dispositioned, 70% did not require invasive mechanical ventilation at any time during their hospitalization, and 61% of those discharged to home or a skilled nursing or rehab facility. So as you can see, a lot of the patients that were able to go home did not over 70% of them did not require mechanical ventilation. They could be supported on nasal high flow. Our nasal high flow patients averaged 5 total days in the ICU, but 33% of them never went to the ICU altogether. October through December 2020 is what I like to call our second surge, or what I like to deem here in the United States, but maybe not well documented yet, was potentially a surge of what we saw, maybe a replication of the COVID or another strain of COVID. We had a definite surge during this time frame. What we had in our hospitals, we had 625 hospitalized COVID-19 patients. Of those, 246, or almost 40%, required escalation of care due to acute hypoxic respiratory failure, and 220 of those, or almost 90% of those patients, received nasal high flow as their escalation support modality from the beginning. 67% of those patients were male with a median age of 71 years old. Of those patients that went home or skilled nursing or rehab, 86% of those, or 134, never required invasive mechanical ventilation at any time during their hospitalization. They averaged about 4.37 days on that nasal high flow device, and almost 70% of them were started on our medical surgical floor. So we were not utilizing, or they were not getting started in the ICU. 56.4% of the patients that started on high flow were dispositioned to home or skilled nursing or rehab. If you did go on a vent, the average time on a ventilator was 11.10 days, with 100% of those patients being in our ICU, because we don't offer the service outside of ICU. For patients that started on the vent first, which were 26 patients that actually started off on a ventilator first, only 38.5% of those actually went home. The remainder of those patients died. What's not on this slide here that I would like to report to y'all too is, if you started on high flow and had to escalate to getting intubated in our facility between this October and December timeframe, your mortality rate was 70%. So only 30% of those patients survived. So what we found from this, and what we can conclude from this, is the use of nasal high flow has been safe, resource sparing, in that we haven't overwhelmed our ICUs. We've been able to take care of most of these patients outside of our ICU. We haven't overwhelmed the use of ventilators in our facility, and we've saved lives by using high flow as an option for these patients. Patients that require mechanical ventilation due to COVID-19 in our facility have a much greater mortality rate than those that are started on nasal high flow. We have known cases of virus transmission to healthcare workers. We have had some respiratory therapists get sick with COVID. 90% of those have been able to be traced outside of the work environment, and the other 10% were in the work environment when people were not following the established infection control protocols that we had put in place. We also found that if we prone positioned some of these patients while they were on high flow, it actually reduced their intubation rates and their mortality rates. Now, some are going to talk a little bit about the cost, what we found within our facility. And this is just looking at staffing levels during the time on the device, specifically looking at nursing staffing levels. So this is not going to take into fact any supplies, so no oxygen, disposables, anything like that, medications. This is only nursing staffing because we wanted to kind of take a look at what was the cost comparison between a patient being in the med-surg unit compared to the critical care unit. And so what you'll see here is that if a hospital can successfully treat an Airvo patient, a patient on Airvo rather than a vent, at least at our institution, it requires less staffing because in the ICU, it's a 1-to-1 staffing versus a 1-to-5 staffing ratio. So you have less staffing out on the med-surg or out on the med-surg floors. So you don't need as many nurses to care for patients that are on these devices. And you have fewer device days than ventilated patients. As you can see, patients tend to be on vents for a little bit longer. As I talked about earlier, they tend to be on the vent for 11 days compared to high flow for about 3 to 4 days. Staffing ratios alone save about $290 per patient day. And overall, the fewer the device days on Airvo than a vent is reduced by 77%. So huge cost savings if you look at it from that perspective for patients that are on Airvo versus a ventilator. At this time, I would like to thank Fisher and Paykel for allowing me to present our information to you today. And I believe we will switch over to a Q&A session now. But if anybody has any questions outside the Q&A or would like to reach out to me for any further details of what we do at our facility, here is my contact information.
It was a excellent and insightful talk, madam. It was good to know that you have used HFNC very much during this pandemic, and you got good results in management of these patients, and you just save the number of ventilator also for the sicker patients. So now for answering the queries in chat box and for the discussion in panel discussion, I would like to invite Ms. Madhuragauri for the next session. She will be the moderator of the next session. Ms. Madhuragauri Shevade is MSc, RRT, NPS. She is respiratory therapist, associate VP of Indian Association of Respiratory Care. She is vice chair of Indian Academy of Respiratory Care. She is associate editor of Indian Journal of Respiratory Care. She has completed her BSc from Symbiosis Institute of Health Sciences, Pune, and she has done her MSc from Rush University College of Health Sciences, Chicago, USA. She has been RT for more than 9-10 years. She has worked in the USA in the neonatal pediatric ICU of Rush University Medical Center. She has also worked with CRF Pune. She is also a visiting faculty and guest lecturer for RT programs in India. Her personal interest and expertise is in research and education in respiratory programs. Publication, she has several publications to her name. So over to you, Ms. Madhura.
Thank you, Dr. Lokesh. Thank you so much. And I would like to also thank the presenters who presented their presentation. Thank you so much. We are running a little late, so let me quickly move on to our panel discussion. So if I can request Jitin to please stop sharing the screen so that we can see our panelists. Let me begin with introducing our speakers for our panelists for today. We are very blessed to have such expertise on board. Everybody has already seen or heard Ms. Julie Jackson. She's the director of respiratory care at the UnityPoint Health Hospital, at Des Moines, Iowa, and she is joining us all the way from the US right now. So thank you for joining us, Ms. Julie. Your presentation was really informative, and it really helped us identify where we can improve at the healthcare in India, and where we can utilize HFNC at our level. So thank you for joining us. The next panelist we have is Dr. Lokesh Kumar Saini. He is an MD respiratory medicine from RNT College, Udaipur. Currently, he is serving as the assistant professor in the Department of Pulmonary Medicine at the All India Institute of Medical Sciences, Rishikesh. He has a vast experience in the field of respiratory care, respiratory medicine, and we are also blessed because he is the course coordinator for our BSc Respiratory Therapy program at AIIMS Rishikesh. He has several publications to his name. He is also a reviewer of multiple national and international journals, and he's also presently conducting multiple funded intramural and extramural projects. He's also associated as a member with the American Academy of Sleep Medicine, the Indian Sleep Disorders Association, and the Uttarakhand chapter of Indian Chest Society. So thank you for joining us, and thank you for moderating the first half of the presentations today, Dr. Lokesh. Thank you so much. Next, we have with us Mr. Akash Soni. He is a respiratory therapist, a senior respiratory therapist, who has done his bachelor's as well as his master's from Symbiosis Institute of Health Sciences, Pune. He is also an adjunct faculty, visiting faculty for Symbiosis Institute of Health Sciences. Currently, he is working as a senior RT at the SL Raheja Hospital, Mumbai. Last year, when the government of India asked for warriors to come forward, he was one of the first ones to come forward and offer his expertise. He is currently serving as the General Secretary of the Maharashtra chapter of IARC. And prior to working in the hospital, he has worked in the corporate setup, excuse me, and he has his specialty is home care. And we have with us Dr. Nigel Fealy. He is a clinical research manager overlooking, I hope I don't make a mistake, Hong Kong, India, Taiwan, Australia, and the China region. And he is here from Fisher Paykel Healthcare. So I welcome all of you here on board, and thank you for joining us today for our session on high flow nasal cannula therapy, or HFNC is what we call here. So the first question, let me take the question that has been that has come from the audience, and I'll leave it to anybody who would like to answer. Is what's the oxygen consumption in high flow therapy? Somebody wants to know how much oxygen gets consumed in high flow therapy.
Look, I'm happy, Madhura, to answer this one, because
Yes.
I think at times there can be a bit of a misconception around high flow oxygen, and we've seen that particularly in my regions, particularly in regions where there's a perception where there is a lack of oxygen or facility to provide oxygen to the hospital itself, whether that's by oxygen tanks or whether it's from the PAT, the large sort of oxygen tanks that hospitals have. And I think that some of that is around the name around high flow oxygen. So if there's a perception sometimes that if the flow on, let's say, an airbo device in our case is set at 40, 50 litres of flow, that means that must mean that there's 40 or 50 litres per minute of 100% oxygen. But the beauty of our devices is that it really is an air and oxygen device, and predominantly much of the flow, until you get to quite high FiO2s, is actually medical air or entrained air. So, whilst you get up to very high FiO2s, yes, there is a lot of oxygen or medical oxygen use. When the FiO2's up to around about 50%, it's reasonably equivalent to something like a non-rebreather at 10 or 15 litres per minute. So there is an equivalence probably at an FiO2 of 0.5 and 40 and 50 litres of flow to a non-rebreather in terms of medical oxygen use.
Okay, thank you so much. That was really nicely explained. Let me continue asking you with another question that keeps coming up at every presentation that we have on, every time that we present on high flow nasal therapy and nasal cannula therapy. I don't know, people keep asking this question about how much PEEP do you deliver? What is the pressure that is generated when this therapy is used? Julie, would you like to answer this question, please?
Sure, I can do that. So what we know is that there is a provision of distending pressure, but the real issue is we can't measure it constantly. What we do know through animal studies is that it's somewhere between, it's roughly about a half to 1 centimeter of water pressure for every 10 liters of flow, approximately. Now that's going to be based on whether the patient's mouth is open or closed, because obviously if their mouth is wide open, you're going to lose a little bit of that flow out the mouth. But for the most part, you can bank on about a half a centimeter water pressure to 1 centimeter water pressure for every 10 liters of flow. So typically what we tell our teams is, if you're at 50 liters of flow, kind of consider that being maybe like 5 centimeters of water pressure approximately. Again, that's depending on if the patient's mouth is open or closed. So that's how we do it based off of the animal studies that were published. Unfortunately, there's no way to constantly measure that pressure. So I don't know that we can honestly say that we know the true pressure, but based off those animal studies, I think we have a pretty good understanding of how that works.
Thank you. Dr. Lokesh, if I can ask you, how has high flow nasal cannula therapy helped during this COVID pandemic?
See, Madhura, as Ms. Julie said, that in the early of the pandemic, we was also not so much sure about the dispersion of infection with the help of with the use of HFNC and NIV. So we were also intubating the patients who were requiring high flow of oxygen. But with due course, we have learned that, if we use a face mask over HFNC in nasal cannula, then the dispersion is very less, and even the studies showing that the dispersion of infection is almost equal to the mask with use of HFNC. So we are using HFNC now. You can say around 50% of patients in our ICU, and what helps us with the help of HFNC is that with the help of HFNC, we can ask the patient to awake proning for more times than the help of NIV. Even in fact, the use of oxygen mask will also a bit interfering in the prone positioning. So HFNC helps us in this way also. Again, for correction of hypoxemia, HFNC corrected hypoxemia more rapidly and more constantly, definitely with the help of a minimum level of CPAP or PEEP also. It gives a recruitment effect in the alveoli, and thus it corrects the hypoxemia. So we are using HFNC very, very commonly in these patients.
Okay, thank you. Akash, are you here? Yes. Akash, so I know you've been also using HFNC even before the pandemic as well as during the pandemic. So can you tell me about what is your opinion? How have you, how do you think it has helped your patients from a respiratory therapist point of view?
So of course, very rightly said regarding the use of HFNC to treat hypoxemic respiratory failure. We have been using HFNC since the pandemic started, and even we were using before that. So we know that HFNC have somehow the effect of a PEEP also, which we talk that every 10 liters of the flow would deliver around 1 centimeters of the PEEP, which will ultimately help recruit the alveoli. And we have seen mostly in the ICU that once we initiate the high flow, we do also prone the patients on the high flow, so that the patients do manage well, and be able to take them out soon from the high flow. So first initiating the high flow to the patient according to the need in the ICU, and then proning them has helped simultaneously improve their oxygenation in the intensive care unit. Moreover, with that, along with that, we have also seen that patients who were highly in the respiratory distress, we have seen that once we started the high flow, soon after half an hour to 1 hour, we have seen that the respiratory rate comes down, even the patients settle down with the tachycardia and started managing well. And then slowly we taper the flow and the FiO2 and put them to the intermediate to low flow oxygen delivery devices. So of course in COVID it has helped us a lot, and as it also has avoided intubation, we have also used a high flow post extubation. So once we extubate the patient after the use, we have seen that immediately after the extubation, we have put the patient on high flow with the moderate to with the moderate levels of the flow of around 40 to 50 with the FiO2 as required as per the SPO for maintaining more than 92%. We have seen that it has helped well, and there are decreased chances of again reintubation in COVID patients post extubation if we use high flow.
Thank you, Akash. We were going to get to that question now, since we are already talking about post extubation. Julie, if you can talk about your experience with post extubation use of HFNC.
Yeah, sure. So we do, much like the previous person mentioned, we do use this post-extubation. Every patient, and this was even prior to the pandemic, we were using it post-extubation. So every patient that is on the vent, that's been on our vent more than 48 hours, automatically gets extubated to high flow. We have found a lot more success that way with them. They end up not getting re-intubated, and most times not even needing non-invasive. We're able to kind of wean them off of that high flow. So anybody that needs it that's been intubated more than 48 hours will get extubated. We actually set the high flow up and on them and have it ready to go, and then we extubate. So it's already on the patient. So there's no like break in time that you're still trying to set them up on something. So we just automatically have it up and ready to go, and then they get extubated automatically to that. We also use it with our tracheostomy patients. So patients that are have tracheostomy, once they're ready to come off the vent, instead of using a standard tracheostomy mask, we'll use a tracheostomy adapter hooked to the high flow to continue to provide them the proper humidification that they need so that you don't have a lot of secretion issues, and also to kind of give them that continued little bit of level of distending pressure, which is minimal, we know, but it gives them a little bit, especially when they first come off the vent, because sometimes we've noticed in the past their work of breathing goes up when they first come off the vent, trying to relearn how to kind of breathe through that trach and not have that vent connected to them. So it tends to help with that process as well.
Okay, thank you so much. Dr. Lokesh, there's a specific question for you. Have you used HFNCs outside of ICU at your institute?
See, the experience of HFNC with us starts with the pandemic only. Unfortunately, we did not have any HFNC unit with us before the pandemic, and in fact, after the pandemic also, we did not have that portable machines with us of HFNC. We are using HFNC with the ventilator only. Some of ventilators having the option of giving high flow oxygen inbuilt. So we had those ventilators, and we were giving HFNC with the ventilators only. So I did not have any experience of using HFNC outside the ICU. We are giving or treating with HFNC inside the ICU only.
Okay. Dr. Nigel, can I ask you a question, or direct a question from the audience? There's a question that is asking, the difference between a standalone HFNC versus the device NIV, which has HFNC, or a ventilator which has an HFNC mode within it. So something like what Dr. Lokesh is currently using.
Yeah, look, we use a combination of the two. So I come from an intensive care background, and similar to what Julie was talking about, we've extubated patients in our ICU for about 9 years now. And so we chose to extubate every patient in the ICU to HFNC. And some of that was because we tend to have 3 to 4 cardiac surgical patients per day. Many of our cardiac surgical population are obese. And even prior to a lot of the publications and studies that came out, which demonstrated that in that particular patient group, there's actually a benefit to patients' prevention re-intubation post-cardiac surgery, we were doing that, but we were doing it really because we thought it was easier for us to do. So there probably isn't much of an essential difference between whether the high flow is coming from the ventilator inspiratory limb via humidification to the patient versus a standalone unit. One thing that I think is of benefit, and maybe Julie could talk to this a little bit, one of the things our nurses do, because we don't have RTs in our system, which I guess, you know, when I look at what's happened around the globe at the moment, when there's an RT-based system as opposed to a doctor-nurse-led system, we've seen where high flow has really been able to demonstrate a difference in patient outcomes. Sometimes in a medical or doctor-nurse system only, there's not that concentrated effort on the respiratory care of patients. And I think an RT-led system, what I've seen in different countries, has really done a good job. But getting back to the extubation portion of this, there are very few times that you get to see what the patient's peak inspiratory flow demand or rate is. But just prior to extubation on a pressure support mode of ventilation, you can actually see what the patient's peak inspiratory flow rate or demand is. And then you can actually use that to set up the flow rate for when you extubate the patient. So it's a very good technique to use so that you can guarantee the FiO2 for that patient on extubation and try and avoid that huge work of breathing that comes immediately in that first golden hour post-extubation.
Thank you. Okay, so can we now move on to some of the questions that are related to infection and infection control. So if I can ask a broad question to you, Julie, can you, what are some of the myths that people have when it comes to healthcare professionals have, as well as patients have, in terms of using HFNC? And also, if you could add a little bit about infection and infection control with this therapy.
Yeah, so I know in the beginning of prior to the pandemic, no one really had much concern about infection control with the device, to be honest with you. No one really even thought about aerosol dispersion, I think, in general before the pandemic. I think the pandemic put that word out there a little bit more, and honestly, I'm kind of tired of the word myself. But anyway, so long story there. But so once the pandemic kind of hit, everyone was, very, worried about aerosol dispersion, rightfully so. We didn't know how far, nobody really knew how far this was going to, the droplets were going to spread, how far we were going to have to do this. And then you're putting something that's generating a lot of flow to the patient. We weren't really 100% sure how much was actually going to come out. So I totally understand everybody's initial panic. But with the research that's been done, and we've been able to show that the aerosol dispersion is not there, I think that the need for infection control and how much infection control you actually do has been drastically reduced. In the beginning, I think everybody thought that these patients needed to be in airborne isolation rooms, needed to be in those negative isolation rooms. But what we were really finding was with how far that droplet actually leaves the patient, if it does at all, there's really not the need for that airborne isolation. Now, in our institution, in the beginning, we did ask the patients to also mask if they were on high flow with a surgical mask when we were around the patient as well. And the therapist, like Dr. Fealy mentioned, the therapists are in there every 2 hours doing patient assessments and making sure the patients are doing okay. So, and we were wearing surgical masks at that point in time as well, surgical mask, gowns, gloves, all that to protect ourselves. But we were not putting you know, PAPRs or N95s or having any of that. Here in the United States, I don't know what it's like everywhere else, but we have a scarce resource of rooms that would be available from the perspective of airborne isolation rooms or negative isolation rooms. So there were a lot of hospitals that were creating rooms. We did not have that capacity to really create a whole lot more rooms at our institution, just by the way it's designed. So we really dived into that aerosol dispersion and really trying to figure out whether that was even going to be an issue or not. So from an infection perspective, we just never really found it. And then from a staff perspective, you know, having the respiratory therapist in that room every 2 hours exposed to the patients and coming back with none of my staff, and I have close to 100 staff RTs, none of them getting sick, that we could link directly back to that therapy. We did have staff get exposed while they were here at work. There was about 10% of the staff that got sick that did get exposed. But we could trace that back to them not following the current infection control plan. Maybe they didn't wear their mask in the room. Maybe they weren't gowning and gloving. Maybe they were, and honestly, those were even in patients that didn't have high flow. They were just your standard oxygen patient maybe, or we had some patients that got admitted to the hospital that never required oxygen because they were having other issues related to COVID, but it wasn't an oxygenation issue for them. And they got exposed that way as well by not following the proper protection. So we felt very confident in that. Now with us prior to, like I said, prior to all this, we weren't following all that. So, and we didn't have lots of exposure of staff to infections then. So we felt pretty confident in that use, especially once the research was published. We felt even more confident in what we had already established as our policy. So.
All right, thank you.
Yep.
Dr. Lokesh, can I ask you how do you see that has there been any difference between the need for intubation when you started using the HFNC therapy, you know, during the pandemic, even before? So whenever you've been using it, do you see that patients who are using the therapy versus who are not using the therapy, is there any difference in the term in them in terms of the need for intubation?
See, one thing I want to make clear, when we were not using HFNC, we were using NIV to those patients when the HFNC was made available to us. So the patient using HFNC and the patient using NIV, there was not a much difference I have observed in terms of intubation rate further. But the issue with NIV was when the patient need NIV for more days, you know, maybe 6 days or 7 days in a row. So use of NIV, compliance with the NIV was very low. When we turn them to on HFNC, then the compliance becomes very good with the use of modality and with the use of proning also. So in that term, it helps us. Otherwise, I didn't see any much difference. I cannot appreciate much difference in rate of intubation. The patients who were very sick in severe ARDS with the low PF ratio, they were intubated eventually with or without use of HFNC.
Right. And I think we saw a little bit of this in the presentations that we had before about somebody who's not doing well on HFNC needing early intubation versus late intubation. So, okay, thank you. Akash, what has been the Indian patients' feedback in terms of using HFNC? Because I know you've been using it since day one. I know you've been using it even before the pandemic. So in your opinion, what has been the overall feedback from the patients? How comfortable are they? You know, all of that. You're muted.
Yeah, so there were days when we initially used to start NIV, and we used to observe that the patient is extremely uncomfortable because of the interface. Okay, because he's getting high pressures, and we used to see that the patient is very less tolerating the NIV mask. And then when we try to switch them from the non-invasive ventilation to the high flow, we could see that there is a good tolerance by the patient, since there is a small interface, okay, which is a nasal cannula, what large bore nasal cannula, and which increases the comfort to the patient. So of course, the feedback when it comes to when it comes to comfort, then high flow nasal cannulas feedback was of course good in comparison with non-invasive ventilation. So we have seen as and if the comfort improves, ultimately, the patient relaxes, and we say that ultimately the patient improves more better, okay, in terms of the tolerance, because ultimately the patient doesn't tolerate well, okay, and we have to remove the mask. If the patient removes the mask, ultimately he will again land up in respiratory distress, and it may land up to emergency. So, our main aim was to first comfort the patient, and we think that HFNC was something which has made it to to the patient to give the comfort the most.
All right. Thank you. Thank you so much. We are running short of time. There are two important questions that I would still like to address. The same question will go for Dr. Lokesh as well as for you, Julie. So, Dr. Lokesh, if I can start with you, how has it changed practice? How has high frequency or high flow nasal cannula therapy changed practice? What is your opinion about it?
See, as I said earlier, in the cases of acute hypoxemic respiratory failure, we used to start with nasal prong and then oxygen mask, and after that, if we do not have HFNC, we were using NIV. So the compliance with the modality was very low with NIV. And one more thing I want to add here is proning, because we know that awake proning helps in these patients. So proning was NIV was hampering the proning in these patients. So when we start using HFNC, it gives us edge over NIV in terms of the compliance of modality and the proning. So the patient improves. I must say that the difference was 60% in the selectively given HFNC to the selected group, not in very severe PF ratio group. But if we used HFNC at appropriate time, then it definitely gives us better result.
Okay, thank you. What about you, Julie?
I would say from our perspective, I'm going to take 2 points to this. The prior to the pandemic, really what it's done is it's drive down some of the unnecessary use of non-invasive ventilation at our facility. A lot of times these patients would come in for us through the EMS system. So they'd be picked up in their home, and especially COPD and CHFers that were exacerbating, they would come in. They don't tolerate the masks, especially when you can't breathe and you put a mask on somebody's face, it just makes it 10 times worse for them. They're just more anxious. And then there's that vicious cycle that they just can't calm down. They can't breathe. And then you end up having to give them a bunch of sedation and medication that they probably don't need either. And then sometimes you knock out their drive to breathe and they get intubated, and it's just a really vicious cycle. So for us, I feel like it's allowed us to have that, especially in the acute hypoxic patient, an opportunity to give them something where they can breathe. They still have the ability to eat. They have the ability to talk. Pandemic wise, we can prone them, like has been mentioned a couple of times, if we need to, and you're not worried about, where their face is and skin breakdown and things like that. We still have to watch for skin breakdown. We still have to watch for those things, with high flow, because if you have somebody that has, poor skin or fragile skin, you still want to make sure that you're not having that. But it's just so much more comfortable for the patients. It's a lot easier for nurses, therapists, physicians to manage, have conversations with patients. The other thing that hasn't been mentioned so far is it's a lot easier to mobilize patients as well on high flow than it is to mobilize them on non-invasive or even on event. So there's just less risk there, and there's less risk of infection for the patient. If you don't have to put them and have to intubate them, you don't have to worry about whether or not you're going to get a ventilator associated pneumonia or they're going to get other secondary infections that come along with being intubated. So I think it's just really changed the practice in general of how we manage those acute hypoxic patients. Now, obviously it's, there's still the data is still out on whether how much it helps the acute hypercarbic patients, and how much it's able to reduce that. But it does give us a bigger tool in our arsenal, and it allows, like in the United States, there's a lot of cost issues related with healthcare compared to other countries. We can reduce the amount of devices we need to have sitting around. We were averaging at our facility on an average patient would end up going through 4 different oxygen devices within our facility before we would even get to that intubation sometimes if they needed to get to that point. So now we literally have a protocol that if they need more than 4 liters of standard oxygen, they go over to this. So we've reduced masks. We've reduced a lot of that expense that doesn't need to be there either. So that's our kind of our take on it here. So.
And are RTs more confident in using this therapy?
Yeah, our RTs are the ones pretty much driving it. They're the ones in the ER telling the doctor, we're going to do this. It's not even an option sometimes that they let the physicians have, which I know sounds really bad, but they're driving it a lot. And and they would rather set this up than to go through 5 different devices trying to figure out what's the right thing for the patient. And they can still talk and communicate to the patients, which is always a struggle, especially on non-invasive, because you can't understand half the time what they're saying to you. And so there'd be a lot of, okay, we got to take it off for a quick second to hear what you're saying, put it back on. I mean, just a lot of that. And in our institution, in our ICU, the nurses, they would have to get our help to help them take it off to give the patient medications or things like that. So it's just really changed a lot of that. And the therapists definitely like it a lot better. So.
Yes, I'm sure Akash will agree with you, a fellow RT working in Mumbai. Okay, there's one question.
You muted yourself, Madhura.
Sorry, I'm sorry. There's one question that has come to me from several sources, and I think although we were not going to discuss much about it, but I think if someone, it's open to all of you. Can you talk about the use of high flow nasal therapy in the pediatric and neonatal population? I know I have used it when I used to work 10 years ago. I have used it in all the tiny babies for all the respiratory distresses and the issues that they suffered. But considering that we may have a third wave of COVID, can this be a solution for our kids?
This is Julie. I will tell you, we've been using it in our kids before we even started using it in our adults. So this dates back to, for us, wow, it's probably been almost 15, 20 years ago, we started using some sort of high flow in the pediatric NICU population. It looks different today than it did back then, but pretty much we've been using it that whole time. And even during this pandemic, we did see some kids that developed COVID and had to use it, and we actually did use it for them as well. So this is kind of commonplace for us here. We use it with all of our viral kids. Instead of doing bronchodilator therapy that doesn't work on viruses worth a darn, we use a lot more high flow, oxygen, support them with hydration and suctioning is really what we do more of. And then for our neonatal population, we are barely intubating our neonates anymore, even the small, tiny little neonates, because we're using our high flow to kind of just manage their bradyas and apneas and stuff like that they tend to have. So that's our experience here.
Yeah, Madhura, I think, Julie's 100% right. If you separate them out, the neonatal population, there's still an enormous amount of research going on at the moment about the utility of neonatal CPAP, bubble CPAP, and where nasal high flow sits in amongst that. And I think there probably was a few years ago where there was a thought process that nasal high flow would take over that bubble CPAP or that neonatal CPAP by a flow driver. But sort of in the last few years, a lot of studies have shown that there is still a requirement for that CPAP device. And I think that probably will continue. And I think probably what we'll see is, as Julie quite rightly pointed out, a reduction in intubation, bubble CPAP or a CPAP type device weaning to high flow for that neonatal population. I think that's what appears to be the trend. But for the bronchiolitis type patients, I think it really has changed practice significantly. So for that kind of, where you have children with RSV, bronchiolitis, hospitals that go to high flow very early see a reduction in intubation in that group, but it also means they can be managed in ward areas as opposed to always being managed in a paediatric intensive care unit. So I think it really has changed, particularly in that patient group. I think it really has changed practice a lot.
All right, that's good. Is there anything else that any one of you would like to add before we move on to the vote of thanks? I know there are a lot of questions that people are now asking. We unfortunately, because of we are short of time, we cannot answer them. But I think we've answered most of the important questions. But if there's something else that you would like to add, please, I leave the forum open to all of you.
So I would like to add here one thing regarding the disinfectants of the machines, especially FNP machines when we use it, because it is very important to disinfect the machine before every patient use. So, and we know that FNP has a concise kit of disinfectants, disinfectants, which includes the disinfectant tubing. Along with that, we have a small sponge brush, okay, and the sponge which we need to clean the boards of it, and then we need to attach the disinfectant tubings to one of the board and close the other board. And at least we would require 1 hour to at least 50 minutes to 1 hour to disinfect the machine. And it is always good if we disinfect the machines before every patient use, would also maintain the quality of therapy of what we give, and of course we'll also maintain the quality of the machine. So this is something which is being added.
Thank you, Akash.
During this pandemic, if another wave came to India, I want to say one thing with my experience, that whatever modality we are choosing for hypoxemia, either nasal prong mask or HFNC, NIV, or maybe intubation, but never forget prone ventilation. Proning is very important. In fact, I have experienced few of our patients after intubation, they were managing SpO2 in the range of 80% only, in fact 78 to 80% only, and after proning of, in fact, we are using prolonged proning in these patients. In spite of recommended 16 hours, when we give them prolonged proning, SpO2 improves, and we could extubate some of them with the help of this only. So the modality is one thing, but the proning is very important, I want to say.
Thank you, Dr. Lokesh. Yes, Dr. Nigel, would you like to add something?
Yeah, look, only two things. One is, I was just thinking about the question that you asked before, but I think one of the things that has come out of COVID is that the increased confidence with the device itself. So it's very unusual to get, this concentrated population of exactly the same condition, in this case, a hypoxemic respiratory failure. And what it's probably done to some degree is it's increased everyone's confidence that you can prevent intubation in that patient group. In other words, you'll tend to see that over winter months with influenza potentially, or bacterial pneumonia. But it's unusual to have a confidence through maybe a 12 or 18 month period of time in exactly the same condition. So that's one point. The second point is that it would be really interesting to know, after all of this is over, for the countries that have an RT-led or an RT-associated model of care versus, as I said before, a different model of care, whether there's a difference in outcomes. Because I guess I come from a system where there are no RTs, and I would say that our model of care suffers from not having that model, because I think if they did examine countries that, you know, where there was just a doctor-nurse versus a doctor-nurse RT system, I actually genuinely believe that the RTs would see a greater or better outcomes. Not to say my system's any worse, but I think that the nurse has to do so many other things that they tend to lose concentration and focus on that respiratory aspect, or potentially have the knowledge that an RT would have. So I think, you know, I think they've played a really important role in this pandemic, and I think what they've done in improving the outcomes can't be understated.
Thank you so much. That is really heartening to hear. And also you've given a really nice idea for somebody to take up a multinational research project. Anybody interested, please, we're all here to help. But it really is, because we do need to explore a lot of avenues when it comes to the use of respiratory therapists in different scenarios, and what better scenario than the current scenario. So if anybody would like to take up this project, I'm willing to help. I'm willing to participate. Julie, would you like to say something before we close?
Yeah, I think the only one thing I want to say is, you know, I know that there's a lot of people around the world, around the country that, you know, don't necessarily feel like they have all the answers when it comes to high flow. And so I really think the best thing, and I'm glad you guys did this today, I really think the best thing is to network with places that do have that. You know, I've seen some of the questions coming through chat. There's, you know, a lot of questions still sitting out there, but, you know, I think networking with places that have been utilizing it, getting their experiences. Of course, you're going to have to tailor it to your institution, because everybody has things a little bit different in their institutions. But I think just asking those questions, reaching out, not being afraid to reach out. It's not a deficit if your institution hasn't been using it yet and you want to use it. It's just a matter of getting the resources and the help that you need, and finding those. And I have yet to find during this pandemic that there's not been anybody willing to share. You know, prior to pandemic, I think there was lots of people that were a little, I want to keep everything to myself until I can publish it and put it out there. But I think now everybody knows and understands how important it is that we have to talk to each other and explain what we're doing, because we all can benefit, and all of our patients around the world can benefit if we do that. So that would just be my last parting thing, is don't be afraid to reach out and ask questions.
Absolutely. Thank you so much. And this this tendency of sharing this time has really helped India, because we really went through a lot in the last few months, and we do have a small group of respiratory therapists here. We have humongous you know, now size of patient population. So any and every help that we can get, exchange of ideas, exchange of knowledge is more, you know, extremely important for us. So thank you for pointing that out, and thank you for being here with us. Thank you, Dr. Lokesh. Thank you, Dr. Nigel. Thank you, Julie. Thank you, Akash, and the entire team of Fisher Paykel. I know Thomas couldn't be here, but thank you to him as well for sharing his insights on the therapy. I do keep following him on Twitter, so I know what all he's up to. Thank you. Yes. Thank you to everybody who's been here all this while. If you all have, I know there are so many questions that we couldn't answer. You can get in touch with anybody from us, from the Fisher Paykel team, from the IRC team, and we are here to help you all answer all these questions offline, of course. With that, thank you, Jitin. He has been our General Secretary, who is actually leading everything, but silently sitting at the back, letting us take charge. So Jitin, I know you're listening. Thank you for all your help. And thank you to all the senior RTs who have helped with the various programs that we've done so far as well. Thank you so much. And we hope to have all of you again on board. We will have a longer discussion time probably, and we'll have more questions and we'll answer them. So thank you so much, everybody.
Thanks, Madhura.
Thank you.
Thank you.
Good night. Good night. Thank you.